Hello, ladies and gentlemen. I'm Hiroshima from Nara Medical University, Japan. It is a great honor to present in this WFH virtual summit. In this presentation, I'd like to talk about substitution therapy, focusing on bispecific antibody, emicizumab. This is my disclosures. In this presentation, I will talk about, firstly, experience of emicizumab prophylaxis in a Nara Medical University hospital. Then I will discuss about application of emicizumab, especially to non-inhibitor patients with hemophilia A. And thirdly, I will discuss about how to assess emicizumab prophylaxis other than ABR. And lastly, I will mention about issues in laboratory monitoring. Emicizumab is a bispecific antibody recognizing factor IXa and factor X and have cofactor function of activating factor VIII by supporting suitable interaction between factor IXa and factor X. This antibody have several advantages. One is effective regardless of the presence of a factor VIII inhibitor. Second, it can be administered subcutaneously. Thirdly, much longer half-life of approximately 30 days, resulting in less infusion. Therefore, emicizumab has game-changing potential to improve the QOL of hemophilia A patients and also their caregivers. From now, I'd like to introduce post-marketing experience of emicizumab in a hospital. At January 22, 2020, totally 59 patients are under emicizumab prophylaxis. Most frequently used patient is 10 to 19 years old age. 66% of the patient is under 20 years old. This indicated that highly active age patients are using emicizumab. This slide shows classification of the patient using emicizumab in terms of inhibitor presence, ITI history, and its success. The percentage of non-inhibitor and inhibitor patients were 68 and 32% respectively. Among inhibitor patients, no ITI case was 12%, and ITI failure cases was 20%. 15% of non-inhibitor cases included ITI success case. No patient relapsed inhibitor after change to emicizumab prophylaxis, and no patient used additional factor VIII in the ITI success group. This slide shows dosing regimen in the patient under emicizumab prophylaxis in a hospital. The most used regimen was every 2 weeks, and the rate was 58%. This may be due to the same dose as loading. The second regimen was every week dosing, 34%. Every 4 weeks was only 8%. This figure shows who injects before and after emicizumab prophylaxis. Before emicizumab, 34% were injected by himself, and 41% of patients were injected by mother. 12% were injected by doctor. After emicizumab started, patients who injected by himself increased to 64%, and patients who were injected by mother was decreased to 34%. The number injected by doctor also decreased to 2%, only one case. And there were 6 patients with CFAD before emicizumab, and all cases could be removed CFAD. Now emicizumab has been approved in over 50 countries, and more than 6,500 patients have been treated. Therefore, emicizumab became one of the key drugs for hemophilia A. However, several real-world questions are evolving in clinical applications. So I will focus on exploring the following clinical dilemmas pertaining to emicizumab prophylaxis. Indication for treatment in non-hemophilia patients, clinical monitoring parameters besides bleeding episode and possible effect on overall bone health, and laboratory monitoring of clotting function. Patients with an inhibitor are definite candidates for emicizumab prophylaxis. However, there are no recommendations or consensus on when to start emicizumab in mild and moderate patients. It may be optimal to start emicizumab prophylaxis as soon as possible after diagnosis, especially in previously untreated patient PAPs. There are several reasons for considering this early prophylaxis. Firstly, complete prevention from hemophilia is limited using the current regular prophylactic regimen with factor VIII concentrates. And another important issue is the risk of intracranial hemorrhage ICH. According to the report of Whitmer, median age of the patient who developed ICH was 2 years old, and 40% of the cases occurred before 2 years old. Therefore, early emicizumab prophylaxis could contribute to the maintenance of healthy joint and prevention of ICH. However, concerns remain about the safety and risk of developing factor VIII inhibitor due to the additional use of factor VIII concentrate for breakthrough bleeding in patients with factor VIII exposure of less than 50 days. Therefore, further clinical studies are warranted to accumulate experience with emicizumab prophylaxis in pups and infants, especially under 6 months of age. For this purpose, clinical studies on emicizumab pups, in addition to Newark ITI study, is ongoing. In the next, I would like to talk about application to moderate and mild patients. Several reasons exist for consideration of this indication. Some moderate mild type have clinically severe phenotype developing arthropathy. Some Z type of patients have higher risk of developing factor VIII inhibitor. Currently, some Z type of patients receive factor VIII prophylaxis. However, there may be concern in reduced emicizumab potential in the TNS complex in the presence of dysfunctional factor VIII. Recently, our group investigated the ex vivo hemostatic effects of emicizumab in moderate and mild patients by clot waveform analysis, CWA. In this study, we tested effect of emicizumab on the clotting function of these 16 cases. As you can see in this slide, maximal coagulation velocity, mean 1, increased in all cases after ex vivo addition of emicizumab in dose-dependent manner. These results indicated that emicizumab enhanced hemostatic potential in patients with mild and moderate hemophilia patient too. Therefore, emicizumab could be beneficial to clinically severe patients with mild and moderate hemophilia A. So in order to evaluate this safety, efficacy, PK, and PD of emicizumab in these type of patients, Haven 6 studies are ongoing. So next, I would like to discuss about how to assess the effect of emicizumab. Since bleeding episode is remarkably decreased by emicizumab prophylaxis in general, we need new assessment for patient outcome beyond ABR. Several post-marketing clinical studies for joint health, physical activity, and non-bleeding symptoms, as well as mild, moderate patients and PAPs, which I previously discussed, are ongoing as shown in this slide. Furthermore, we need to assess unrestricted life, psychological health too. Recently, arguments regarding bone health in hemophilia A patients on emicizumab prophylaxis are arising. This concern is derived from the concept that exposure to factor VIII will likely be markedly decreased while on emicizumab prophylaxis, leading to possible concerns about bone health status in the absence of factor VIII. According to the report of Gay et al., retrospective surveillance spanning 10 years revealed that the rate of bone fracture in both hemophilia A and hemophilia B was much higher than in the control population. Furthermore, Davis et al. Reported that an osteoporotic phenotype was observed in both factor VIII and factor IX knockout mice, but not in von Willebrand factor knockout mice. This suggested the significant role for factor VIII and factor IX in bone health. However, alternatively, Pate and his group recently reported that degree of physical activity is associated with improved bone health in children 3 to 6 years old. So although we need long-term observation of bone health to answer this question, better bone structure could be maintained with the use of early emicizumab prophylaxis by facilitating greater mobility. In Haven studies, only inhibitor patients were assessed in pediatric group of patients. Therefore, clinical studies on pediatric non-inhibitor patients are limited. So I'd like to introduce clinical studies for this group. The HOHOEMI study was a Japanese multi-center open-label non-randomized study of emicizumab in pediatric hemophilia A patients less than 12 years old without inhibitors. There were 2 dosing cohorts at a maintenance dose of 3 mg per kg every 2 weeks Q2W and 6 mg per kg every 4 weeks Q4W. The number of participants in Q2W and Q4W was 6 and 7 respectively. The latter arm included a pup with 4-month-old. The objectives of this study was to investigate the efficacy, safety, and PK of emicizumab Q2W and Q4W in pediatric without inhibitor by assessments of ABR, incidence of adverse events, incidence of anti-emicizumab antibody, factor VIII inhibitor, and we also performed preference survey and activity survey. The upper table shows the demographics and baseline characteristics of the participants. The mean age of the Q2W was 6.62, and the range was 1.5 to 10 to 72. In Q4W, the mean age was 4.799, and the range was 0.33 to 8.11. All patients received prophylactic treatment with factor VIII before start of emicizumab, except for one case. The lower table shows the summary of ABRs. The model-based treated ABR in Q2W and Q4W was 1.3 and 0.7 respectively. All bleeding rate was 14.1 and 21.8 respectively. In this study, all caregivers completed the survey at 16 weeks post-treatment for preference for emicizumab over their former treatment. All caregivers preferred emicizumab to the patient's previous treatment. The important reason was the frequency of treatment was less. Effect on other activities such as job, school, sports, and social activity was less. Worried about finding vein was less, and route of administration was easier. We started our study after approval of emicizumab for non-inhibitor patients. All patients who participated to HOHOEMI study transitioned to this study. Furthermore, additional patients also participated. There is no limitation in dosing regimen. The objective of this study is evaluate the long-term safety and joint health with administration of emicizumab prophylaxis. Scope of data for the analysis is safety, MRI score, and HAHS and activity survey. Lastly, I would like to discuss about laboratory issues. Emicizumab-driven reaction commences at the initial phase of blood coagulation, involving factor 9A generated by factor 7A and tissue factor, and therefore do not depend on thrombin activation. This unique characteristic makes it difficult to assess emicizumab potential using the ABDD or ABDD-based factor assay. Right figures show the change in ABDD in the patient who participated to 3-dose cohort in the phase 1 study. So as you can see, ABDD extremely shortened even in the lowest dose cohort, and there is no dose relationship. Chromogenic assay using primate or human reagent may be utilized. However, currently available testing using bovine reagent cannot be used for this indication. Alternatively, global assays might be applicable. There are 3 candidates. One is TEG and RO10. Although these techniques do not provide precise quantitative measurements, semi-quantitative assessment could be helpful, and the techniques are widely available. Furthermore, non-activating system NATEM is better than INTEM. Thrombin generation test TGT also provide an option, although the results are limited. In this assay, standard tissue factor trigger is less sensitive than factor 11A trigger. Lastly, clot waveform analysis could also prove useful for monitoring of emicizumab prophylaxis. This slide shows RO10 assays including XTEM, NATEM, and INTEM using whole blood from the patient with hemophilia A with emicizumab added ex vivo. The parameter CT plus CFT in the XTEM assay, as shown in the left side of this slide, were little affected by addition of emicizumab. INTEM, as shown in the right, demonstrated significant response to emicizumab. However, there appeared unlikely to be significant difference between the result at different concentrations of emicizumab. In contrast, the NATEM assay demonstrated significant dose-dependent improvement. Therefore, these results strongly suggested that non-activating NATEM is more useful than activating XTEM and INTEM. The left figure shows the NATEM parameters, clotting time CT in 27 cases of severe, 30 cases of moderate, 24 cases of mild hemophilia A, and 20 normal individuals. You can see that significant difference was observed between severe and mild type, moderate and mild type, and mild and normal individual. The right figures show relationship between clotting time and emicizumab concentration in whole blood from patients with hemophilia A who participated to clinical trial on each of their individual visits, including loading phase. The CT inversely correlated with plasma concentrations of emicizumab at the indicated time points. The minimum emicizumab concentration at which the mean CT in moderate and mild type level was 10 and 18 micrograms per ml, respectively. So these results suggested that NATEM is useful for monitoring of emicizumab prophylaxis, and coagulation function was improved in these patients at lower concentration than those previously reported to be clinically applicable in the steady state around 50 micrograms per ml. This slide shows the modified clot waveform analysis using mixed PT and APTT reagent in hemophilia A patients without or with inhibitor after ex vivo addition of emicizumab. Maximum coagulation velocity at mean 1 increased dose dependently on the emicizumab concentration in plasma sample of all 5 cases without inhibitor and all of 9 cases with inhibitor. These results suggested that the mixed PT and APTT reagent trigger CWA could provide a useful means of assessing global coagulation potential in emicizumab-treated hemophilia A patients. This slide shows the effect of bypassing agent on NATM and APTT and PT-triggered CWA in a total of 9 episodes of bypassing agent infusion for hemostatic management in 2 emicizumab-treated patients with hemophilia A. Coagulation potential was assessed just before and 30 minutes after BPA infusion. Treatment with APCC at concentration ranging from 44 to 73 units per kg, shown by closed circle, was associated with shortening of the CT in NATM to the normal level. Furthermore, maximum coagulation velocity at mean 1 increased in 2 episodes, as shown in the right figure. Similarly, by the recombinant factor 7 infusion ranging 79 to 93 microgram per kg, shown by open circle, CT in 5 of 6 episodes shortened within the normal range. The CWA mean 1 also increased in all episodes, although these higher levels were not within the normal range. These results suggested that the ROTEM and APTT-PT trigger CWA is useful for monitoring of concomitant use of bypassing agent under the emicizumab prophylaxis. In clinical setting, there will be a case when we need to measure factor VIII and factor VIII inhibitor during emicizumab prophylaxis. For supplementary hemostatic management or during perioperative periods in patients without inhibitor, or in routine clinical practice for pediatric patients, early detection of factor VIII inhibitors and monitoring of inhibitor titers are also essential. So for this purpose, chromogenic acid with warfarin reagents are recommended by UKHCDO guidelines. However, there are still many countries where only APTT-based factor measurements are readily available. So in order to overcome this issue, an APTT-based factor assay utilizing anti-idiotype monoclonal antibodies has been recently established. In order to prevent interference by emicizumab and to enable accurate measurements of factor activity and inhibitor titers, we produced 2 anti-idiotype recombinant monoclonal antibodies against emicizumab by immunization of a mouse by factor 9A arm alpha FAB'2 of emicizumab and immunization of a rat by factor 10-1 armed FAB'2 of emicizumab. Figure A shows the shortening effect of emicizumab on APTTs of factor deficient plasma was eliminated at all incubation times by addition of anti-emicizumab monoclonal antibodies. Figure B shows that the anti-idiotype mixture inactivated emicizumab completely at all concentrations, utilized without the inhibitor as shown in the left figure and with inhibitor in the right figure. This technique could provide a major advance for measurements of factor activity and factor inhibitor during emicizumab prophylaxis. Furthermore, this neutralization by anti-idiotype monoclonal antibody would be applicable to other APTT-based assays. The last issue is detection of anti-emicizumab antibody. In the process of optimization of emicizumab, immunogenicity was maximally minimized by amino acid substitution according to in-circle assessment. Therefore, generally, rate of neutralizing anti-emicizumab antibody is quite low. In all Haven studies, only 3 cases out of 398 patients developed neutralizing ADAs. However, neutralizing ADA cannot be excluded, and therefore, we need to detect ADA in clinical practice. So for this purpose, APTT is very useful. So in conclusion, emicizumab prophylaxis could be applied to early infants, including pups and mild and moderate patients. HOHOEMI study confirmed safety and efficacy of emicizumab prophylaxis in pediatric patients, including PAPs. Clinical assessment of emicizumab prophylaxis other than ABR-based estimation will be required and standardized. ABTT and ABTT-based factor A assay cannot be utilized for emicizumab monitoring, and chromogenic assay with human reagents and global assays would be useful for monitoring of emicizumab potential. And chromogenic assay with bovine reagents and ABTT-based factor A assay with anti-idiotype monoclonal antibodies can be utilized for measurement of factor A and factor A inhibitor during emicizumab prophylaxis. And ABTT is useful for detection of neutralizing ADA. Lastly, I'd like to emphasize that longer observation and experience would be required. I'd like to express my special thankfulness to my colleague in the Department of Pediatrics, Nara Medical University, and excellent children investigators. So thank you very much for your attention.
Hello, I'm Dr. Robert Sidonio, and thank you very much for allowing me to come talk today about the current status of clinical trials regarding emicizumab prophylaxis, specifically with a focus on ITI. I'm an associate professor of pediatrics at Children's Healthcare of Atlanta at Emory University, and that's in Atlanta, Georgia, the United States. Here are my disclosures, and the most important ones are that my clinical trials are funded by Octapharma and Genentech, and Dr. Guy Young's trial is funded by Genentech. So the current state, we have a few challenges. One of the challenges that we have is whether we decide to give a structured factor VIII regimen to those that we've started on emicizumab as pups, and will this have an effect on their inherent cumulative incidence of inhibitor development? We know that a third of patients that are pups with severe hemophilia A will ultimately develop an inhibitor. We currently don't have any strategies to really stop that, short of utilizing plasma-derived products in low-risk groups, as mentioned in the SIPPET trial. We know that most patients develop it by the first 20 exposures, and certainly the vast majority develop it by 50 exposures. There are a number of genetic and environmental risk factors, and of which we only have an effect on the latter. The Germans attempted a strategy long ago in which they felt that early introduction of low dose factor may lead to a reduction of inhibitor incidence. As a strategy in the United States, we typically start off at once to twice a week on this regimen. As you can see here, step up as soon as possible, eventually advancing to approximately 3 to 4 times a week, which is the strategy that most employ in the Western world. The Germans decided during their tolerization phase, as they called it, to avoid those danger signals which may lead to inhibitor development, and that meant reducing the number of immunizations, administering low-dose factor in a non-stressful, non-danger signal setting, and doing this with nursing help. And with that, their early data from their single institution showed a very low incidence of inhibitors. However, as they attempted to apply this in a clinical trial setting in a phase 3 study, 8 of the first 19 subjects developed an inhibitor, which gave an incidence similar to what we see with other products. And whether you believe that all of these were inhibitors that would have led to a high titer inhibitor, we know that it's highly unlikely that they would have found a positive finding based on that strategy. And it wasn't because the strategy was a failure, it was that they didn't have the appropriate product that actually could give them the outcome that they needed, and we'll talk about that in a few slides. The other challenge that we have is that patients that start emicizumab will often have delayed factor VIII exposure, and that can be a good thing, of course. And we do know that patients that utilize factor VIII prophylaxis ultimately develop an inhibitor if they are within 4 to 5 months of exposure based on the typical standard of once or twice a week. We know that patients on emicizumab may not reach that 50 exposure days during their pediatric age group, and thus a little bit of a concern because inhibitor development may be pushed until an older age. We don't know what the implications of that are currently. The other thing that we're coming to realization is whether ITI will be relevant in this emicizumab age. We know that MASAC, our guiding group in the United States, still recommends ITI as a strategy. Various other groups, including NHF, mention that ITI should be started as soon as possible after a high titer inhibitor is identified and should be considered at least once, particularly those in younger age. We know there are various number of strategies of which I don't have time to go through. But more recently, and the emicizumab listed here is weekly, and it could be any frequency that's per label. The strategy that we've identified is the Atlanta protocol that we developed here with myself, Dr. Meeks, Fatsuli, Zamowski, and Kelly Tickle, in which emicizumab is given in conjunction with factor VIII at a dose of 100 units per kilo 3 times a week, regardless of the day and time of the day. The current strategy that we have, at least in the Western world, is that patients are offered ITI based on their prognostic risk factors. And if they don't have a significant drop in their peak titer after 9 months, a product switch is done, intensification or potential adding of an immune suppressive therapy. And then we go on for many, many years, pushing 3 to up to 10 years for some patients to achieve success. Obviously, this isn't going to be what the future is. And now a patient develops an inhibitor. They may either start with emicizumab alone and delay that ITI, or they may start as low as 50 units per kilo, escalating over the subsequent 6 to 9 months, and again, making a decision whether it's a futile effort to attempt to achieve ITI. I will go over briefly the data from our individual center. And again, it's the combination of either recombinant or plasma-derived factor VIII, 100 units per kilo 3 times a week, plus emicizumab per label, and starting after the loading phase. We described in hemophilia last year 7 patients, of which the majority had a high titer inhibitor, had at least 1 attempt previously, and had an elevated titer at the start of ITI. As you can see in this table, 4 of the 7 have been able to achieve a negative inhibitor titer with a normal peak, normal recovery, and currently are at the point where they're attempting to reduce the exposure to factor VIII over an unknown period of time, likely over the next 6 to 12 months. And we'll talk about Dr. Guy Young's attempt to get at this question. Briefly, the patients did very well. There were no evidence of thrombotic complications, no TMA episodes. The bleeding was in line with what you would see in a clinical trial. And we actually didn't see an anamnestic response, short of 1 patient that had a mild response, but then subsequently responded very quickly. So why the Atlanta protocol? Well, it's less burdensome. The number of infusions is in line with strategies of factor VIII prophylaxis that we see outside of inhibitor development. We could achieve ITI potentially quicker, for sure. We know that patients will continue to be at risk of events for thrombosis and TMA. Those events are highly unlikely in the setting of a non-inhibitor patient. We know that we would like to offer gene therapy patients to those trials, to these patient population, but obviously they'll need to have resolution of their inhibitor. And we know that life-threatening bleeding events are going to be less rare with the novel therapies compared to those with inhibitors, which will still be at risk, and we see that even though they're infrequent. And we would like to be able to return to factor VIII as an ability to resolve bleeding episodes, which is probably the ideal strategy moving forward. So I'm going to go through the various clinical trials that are available. The first one is our clinical trial, and you can see the investigators here. This is an investigator-initiated study with the goal to reduce the inhibitor incidence and to demonstrate the safety in the pediatric or pup population. We're accepting patients less than 3 with moderately severe heme with 2 or less exposures to factor VIII. So this is a 2-year study, and patients will be introduced to weekly or every other week low-dose Nuvic as provided by Octapharma for the trial, and be exposed for 50 exposures or development of an inhibitor. We will evaluate the ITI regimen in Part B of this study, but Part A will focus on the pups. Part B in the same study is going to be attempting to look at the Atlanta protocol in a very multi-center setting. We're looking for 20 patients in 13 centers, and again, have to have 2 occasions of a low titer or high titer inhibitor within 8 weeks of enrollment, and the typical other inclusion-exclusion criteria will be required. For this study, emicizumab will not be allowed, not provided because it's FDA approved, and Nuvic will be provided by Octapharma as a strategy outlined because of potential insurance issues with obtaining it locally. Additionally, we decided to have an international approach. Octapharma is funding this study. It's called the Motivate study. It'll be characterizing ITI strategies with and without emicizumab. And we're looking for 120 patients at 30 centers. We have sites identified in Europe, in the US, and soon to be in Canada, looking any patients of any age with any severity that has an inhibitor as measured as a high titer inhibitor. Patients will be treated at the discretion of their local investigator. Products are not provided as part of the study. ITI will be looked at as part of the Octapharma products alone in Arm 1. We'll compare that to the combination of the Octapharma products with emicizumab as part of the Atlanta protocol. And then Part 3 as part of routine prophylaxis with emicizumab as a control arm. And I forgot to mention Dr. Carmen Escarola is my co-PI on the study and will be leading the EU effort. Primary endpoints will be the same as any other clinical trial with inhibitors, and we're hoping that the time period of 5 years will allow us to collect meaningful data. And this study has now opened in the EU and is very soon to be open in the United States and Canada. So there's some remaining questions as we finish up there. Will tolerance persist after 50 exposures, as in my clinical trial or in patients that have been exposed to that? Once tolerance has been achieved, how much factor VIII exposure is needed? We know that we plan to continue with weekly exposure and then wean over the next 6 to 12 months. We know that adherence to post-ITI prophylaxis does not seem to predict the relapse rate or whether somebody truly has an inhibitor. And at the time, we weren't using fluorescence-based assays. And the priority study is going to be a great study that's going to be underway soon by Dr. Guy Young. So this one is going to compare weekly factor VIII to no factor VIII. Still can continue to lean on it to tolerize our patients, and it's the only effective means to inhibitor eradication. You should consider it in the young child with a newly developed inhibitor, and there are many unanswered questions that we hope that science and clinical trials will answer in the next few years, and we hope that some of you will be able to participate in these studies if they're available. So thank you very much.
I'd like to thank the organizers for the opportunity to be here today. I will be discussing the emicizumab pediatric experience, both in clinical studies and in the real world setting. These are my disclosures. Now, you've heard from the prior speakers some of the topics of ongoing discussion regarding emicizumab prophylaxis in clinical practice, so I won't go over those again. However, the use of emicizumab in adults 18 years and older is well established in clinical trials, as is the benefit risk in pediatric persons with hemophilia A. However, admittedly, in infants, clinical trial data are limited, and the optimal time to start emicizumab prophylaxis has yet to be defined. And so, however, we all know the benefits of early intervention, and you can see some of those on this slide. On the left, data from the joint outcome study showing that in those with early prophylaxis, by the age of 6, 93% have no osteochondral joint damage versus only 58% of those with episodic or late prophylaxis. And you can see that benefit of early prophylaxis relative to episodic treatment or late prophylaxis continues at the age of 18 in this study. Now on the right, you'll see a study of 1,515 children and adolescents with severe hemophilia A or B. And in those, you'll see, not surprisingly, that for those who were treated on demand, the incidence of intracranial hemorrhage, both traumatic and spontaneous, is much higher than for those who received prophylaxis. Now, looking at a different study that had 580 hemophilia patients ages 0 to 2, 207 of those were neonates. And when you look at the causes of bleed in those neonates, 20% are in the head. So that is the second most common cause of bleed. And when you look at those, 51% of them were intracranial hemorrhages. So all this to say that there's definitely a need to start prophylaxis as early as possible and a desire to start prophylaxis as early as possible. But as you'll well know, with the current factor VIII therapies, prophylaxis is often not started until a year of age or later due to the difficulties with intravenous access in young children. Now with emicizumab, there's an opportunity to start earlier given the subcutaneous dosing. And therefore, we felt that it was important to really understand the totality of evidence available for the pediatric population of people treated with hemophilia A. So starting with clinical trials, there were 145 pediatric patients enrolled across the HAVEN studies and the HOHO-EMI study. The majority come from HAVEN 2, where there were 85 under the age of 12, and there were 13 under the age of 12 in the HOHO-EMI study. The others are adolescents that were in the HAVENS 1, 3, and 4 studies. Now, starting with HAVEN 2, the study had 3 arms. This is just a quick reminder of the design. It had 3 arms. The largest arm of 68 people was looking at every weekly dosing, and then there were 2 arms looking at every other week dosing and every 4-week dosing, each of which had 10 people enrolled. So when you look at the every week arm, the weekly dosing arm, there were 65 in that arm, and the treated bleed rate is very low at 0.3 with a median ABR of 0. And you can see on the right, 77% with 0 treated bleeds, and the remainder with only 1 to 3 treated bleeds. Now this was looking at an efficacy period of about 58 weeks median. And importantly, 90% of the bleeds that the treated bleeds that occurred were traumatic, not spontaneous. And really remarkably, when we looked at target joints, there were 23 participants who had target joints prior to study and who were on study for more than a year. And of those, there were 45 target joints and 100% of them resolved. So no target joints left in these participants by the time they had reached a year on study. Now looking at the every 2-week and every 4-week data, just briefly, the bleed rates were low in these as well, 0.2 in the every 2-week and 2.2 in the every 4-week dosing, with high numbers with 0 treated bleeds. Now you can see the efficacy period is quite a bit shorter for these arms. They were started later, so approximately 20 weeks median efficacy period. And we believe that this in part accounts for the slightly higher bleed rate that is seen in the every 4-week cohort, which was primarily driven by 2 participants. And corroborating this are the data that you saw from Professor Shima that I'll show briefly as well from the HOHO-EMI study, showing that the bleed rates in the every 2-week and every 4-week cohorts were not different. And so across all 3 regimens, weekly, every 2 weeks, and every 4 weeks, 100% of participants had 3 or fewer treated bleeds. In terms of safety, emicizumab was well tolerated in the study. There were no thrombotic events, no thrombotic microangiopathies or fatalities. The most common adverse events were nasopharyngitis and injection site reactions, and this is consistent with the adult studies. All of these injection site reactions were mild with no discontinuations due to these ISRs. There were 21 serious adverse events, of which only one was deemed related by the investigator, and that was an anti-drug antibody with neutralizing potential. Of note, there was another anti-drug antibody with neutralizing potential in this study, but that person had no treated bleeds, and that anti-drug antibody spontaneously resolved. And then briefly, you saw these data from Professor Shima, but again, showing in the HOHO-EMI study, so pediatric non-inhibitor patients, the every 2-week dosing and every 4-week dosing had similar bleed rates of 1.3 and 0.7, in fact, slightly lower in the every 4-week dosing. Again, corroborating that there really should not be a difference in efficacy between these regimens. And there's a slightly longer efficacy period here of 34 to 40 weeks. The safety was similar in this study to the other studies, with no thromboembolic events, TMA, or systemic hypersensitivity reactions observed in this study, and no anti-drug antibodies. And similarly to the HAVEN 2, across both regimens, 100% of patients had 3 or fewer treated bleeds. Now moving on to real-world experience, this comes out of Sheba Medical Center, and this is a cohort of 11 young children. The youngest was 2 months old, all with factor VIII inhibitors. Of these, none experienced any hemarthrosis. There was improvement in thrombin generation in all, and 7 of the 11 did not require any additional therapy to maintain hemostasis. There were 2 minor surgeries performed without supplemental therapy. In one of these, there was a complication of a major bleed. This was a circumcision. Interestingly, this little boy had had a port removal prior without any complications, but with the circumcision, there was major bleeding requiring treatment. And also, interestingly, the authors reported a lower ETP for thrombin generation assay in this individual relative to the others who were slightly older, and an increase in the ETP as this individual got older and was looked at again at 6 months of age. So that's an interesting finding that will be interesting to look at in subsequent studies in more individuals treated at these younger ages. From the safety perspective, no thrombotic events or TMAs, and again, there were some injection site reactions, but these were mild without requiring treatment. The next real-world data set comes out of Portugal, and this is a single center experience of 8 children with factor VIII inhibitors. All of them had 0 spontaneous bleeds and 0 joint bleeds. One followed for a median of 48 weeks. And there was an intra-patient comparison done here with 3 of them, and they compared to their prior prophylactic bypassing agent, they had 100% reduction in bleeds. There were no safety issues noted in this study, no thrombotic events, and no abnormal laboratory parameters in every 3-month evaluation. Next, we have a very large multi-center cohort of more than 90 patients, actually, of which 74 were without factor VIII inhibitors, and you see those on the left, with a pre-emicizumab bleed rate of 1.6 and a drop to 0.4 post-emicizumab. Now, in the children younger than 12 years old, you can see the breakdown in those 0 to 2, 2 to 6, and 6 to 12 as you go from left to right. And in all of those age groups, there was a similar low, very low bleed rate of 0.2 to 0.5 ABR, and all decreased from prior treatment, prior to emicizumab. There were 28 children under 18 who underwent surgical procedures, and 90% of those had no bleeding complications. And there were 89% with no bleeds in the 74 without factor VIII inhibitors. There was no discontinuations, no clinical loss of efficacy, and from a safety perspective, no thrombotic events, TMAs, or fatalities. And then the last real-world data experience that I'll show comes from the Hemophilia Center of Western Pennsylvania, and this was looking at 42 people with hemophilia A with and without factor VIII inhibitors. Of those, there were 17 that were under 18 years old. The data are not split by adults and children here, but you can see that for the whole cohort, if you look at the left side part of the slide, the bleed rates were quite low, consistent with the other studies for those with factor VIII inhibitors and those without. Emicizumab was well tolerated. There were 7% with injection site reactions. And there was, importantly, one case of TMA observed on this study. This was in an adult who had undergone a hip replacement for which he received factor VIIa, continued to have bleeding, and therefore was given FIBA. And despite discontinuation of emicizumab 30 days prior to the surgery, it does appear that this person experienced the drug-drug interaction that is well documented in the label when emicizumab is administered concurrently with FIBA. There were 15 surgeries performed across 10 pediatric and adult patients with 0 bleeding in 11 of the 15. And then lastly, I wanted to show what ongoing studies are, what studies are ongoing and which studies are planned in order to continue to fill key remaining knowledge gaps. We are participating in the PEDNET registry that you're all familiar with, and we anticipate a nice data set coming out of that at the ISTH. We're also participating in the CBDR, UK HCDO, and Athens 7 registries. There are 2 studies at Chugai, the AZORA study, which is a continuation of the HOHO-EMI study, long-term follow-up, and then the Tsubasa study is a new study that will explore the relationship of exercise to bleeds and will enroll children and adolescents in addition to adults. You're well aware of the Hemlibra PUP and Newick ITI study that Dr. Sidonio discussed. And then I'm really happy to announce for the first time publicly the existence of the Haven study that we will be starting this, Haven 7 study that we will be starting later this year. This is an infant study, so pups and MTPs that will be treated with emicizumab initially for a year with then 7 years of follow-up. And this is to investigate the safety, efficacy, PK, and PD. So we will have in that study thrombin generation and other PD markers to be able to look at some of those things that have been seen in the other studies. And we will be able to describe long-term outcomes such as safety and joint health. So we're very excited to start this study, which was in collaboration with several people that you likely know in the community. And we really hope that this study will be able to bring a very important data set to the community. So with that, I will thank all of the contributors to these data, including the publication authors, especially the participants and their families. And we're very grateful to the publication authors for publishing their real-world data experience, which is hugely important to those just starting to incorporate emicizumab into their practice. And I will take any questions in the Q&A session. Thank you very much for your time.
Thank you to the organizers for the opportunity to contribute to this session. I'll be presenting on fitusiran, an investigational small interfering RNA therapeutic for treatment of people with hemophilia A and B with or without inhibitors. These are my disclosures. Therapeutic rationale for lowering antithrombin as a treatment for hemophilia comes from the observation that hemophilia A and B are caused by imbalances in hemostasis due to factor VIII and factor IX deficiency respectively, resulting in insufficient thrombin generation. Fitusiran is designed to lower antithrombin levels with the goal of promoting hemostasis via achieving sufficient thrombin generation. Milder bleeding phenotypes have been observed in people with hemophilia who have co-inherited thrombophilic markers, such as antithrombin deficiency, and preclinical and clinical studies support this hypothesis. Now, as a first-in-class siRNA, fitusiran has the potential to offer some advantages for treatment of hemophilia that could potentially transform this compared to other platforms. It is an option for hemophilia A and hemophilia B, as well as for patients with or without inhibitors. has the potential for a consistent or steady state level of hemostatic protection. It's once monthly subcutaneous dosing that's a small volume, does not require any reconstitution, and it's a fixed dose that's not based on body weight and stable at room temperature. This outlines the global clinical development plan. Safety, tolerability, PK and PD and dosage setting was explored in the phase 1 program that included an open label extension. Efficacy and safety is being investigated in the active phase 3 program in adolescents and adults with different eligibilities across 3 protocols. And upon completion of the phase 3 endpoints, patients had the option to continue in an open label extension that will serve to report long-term safety and efficacy. Pediatric trials are now enrolling, and there will also be an extension study for those subjects. The antithrombin lowering occurs quickly upon dosing, reaching a nadir beyond 2 weeks post-dose, and is sustained at levels at or below 20% in subjects who remain on monthly prophylaxis. This antithrombin knockdown is reversible but takes time. After a clinical hold was imposed following a fatal thrombotic event, it was observed that subjects recovered to more than 60% of their normal antithrombin level at 4 months after dosing interruption, and can be observed at normal levels within the year. The phase 1 study and phase 2 open label extension interim analysis showed decreased annualized bleed rate, whereas the bleed data that I'll be presenting here is just from the open label extension study. The difference in the inhibitor and non-inhibitor population duration in the observation period was because phase 1 part D, which was the inhibitor population, started later than the non-inhibitor cohorts. The updated annualized bleed rate data will be presented at the late breaker presentation by Dr. John Passy on Friday, March 19th. But this previous interim cut of the data shows excellent bleed control when on consistent prophylaxis with fitusiran. Now, this degree of antithrombin knockdown can move patients to within the normal range or approaching the normal range for thrombin generation. And accordingly, the addition of exogenous factor concentrates, including bypassing agents, can further augment thrombin generation. So this presents a potential thrombotic risk that requires a new approach for management for breakthrough bleeding events. These breakthrough bleed management guidelines were implemented after the lift of the phase 2 open label extension clinical hold. And these recommendations include substantially reduced dosing for single doses, maximum dose, and interval for follow-up doses. As you can see, for factor VIII, recommended single dose is only 10 units per kilo, max dose of 20 units per kilo, and repeat dosing not recommended within the first 24 hours. And accordingly, for factor IX, standard half-life, extended half-life, APCCs, and recombinant factor VIIa. With the extensive follow-up since the lift of the clinical hold, we've had the opportunity to evaluate how well subjects, together with their caregivers, have been able to adhere to these guidelines. There were 238 bleeds in 15 subjects for this analysis. Compliance with the single dose is indicated in blue. Repeat dose compliance is in solid beige. In contrast, non-compliance is indicated in hashes for the respective colors. The overall compliance for hemophilia A with and without inhibitors and Hem B without inhibitors was 90, 86, and 93% respectively. There were only 2 subjects with Hem B with inhibitors, but the compliance was 64%. The overall rate of compliance for all subjects was 79%, or 187 of 238 treated bleeds. This graph shows some more granularity on the 51 non-compliant bleeds, of which 36 were from a single subject, one of the Hem B with inhibitor subjects. The other 15 bleeds were observed across 8 other subjects. The non-compliant bleeds were treated with either a higher dose or a higher frequency of factor or bypassing agent than the bleed management guidelines recommended. There have been 7 major surgeries that have been managed during the phase 2 open label extension. In each case, factor replacement and bypassing agents were used for the perioperative management, and no antithrombin replacement has been required. I'd like to present my experience with one of these major surgeries, as I found it quite remarkable. This was a 34-year-old with severe hemophilia A enrolled in the open label extension since October of 2019 after he had completed the phase 3 trial. He had demonstrated good efficacy with fitusiran throughout, including demonstration of effective bleed management according to the bleed management guidelines. He had a 3-month history of intermittent postprandial epigastric pain, and ultimately he was diagnosed with biliary dyskinesia. The proposed treatment was a laparoscopic cholecystectomy, which was done in November of 2019. The surgical plan for this, we had proposed a preoperative dose of recombinant factor VIII at 1,300 units as an IV bolus, which was approximately 20 units per kilo based on his body weight of 65 kilos. Then a follow-up dose of recombinant factor VIII, 1,000 units or 15 units per kilo, 12 hours after the initial pre-op dose. And then the recombinant factor VIII would be continued once daily at 1,000 units for post-op days 1 through 3, so an additional 3 doses. For thromboprophylaxis, we chose to use sequential compression devices only. His outcome was very good. His surgical hemostasis was rated as excellent. Estimated blood loss was 10 mLs. He showed a stable hemoglobin hematocrit throughout the postoperative period. No blood products were administered, and he was discharged home day 3 post-op. Now, interestingly, because I also run the clinical laboratory, I decided to embargo any laboratory monitoring for him from the special coag lab until he was discharged. My rationale for that is I didn't want a overly eager house officer or someone who wasn't familiar enough with the protocol to see what would be a low factor VIII level and request an infusion over on top of what I had already recommended. This is just showing some of the labs from his post-monitoring phase. 12 hours post-infusion of a 15 units per kilo dose, his chromogenic factor VIII was just 12%, and 24 hours post-infusion on the same dose, his chromogenic factor VIII was only 5%. So this was clearly the least amount of factor coverage I have ever used in a severe hemophiliac for a surgery like this. And so really shows the efficacy of the antithrombin knockdown. So in summary, fitusiran is an investigational siRNA therapeutic that shows potential for treatment of people with hemophilia A or B with or without inhibitors. Long-term exposure to fitusiran in the phase 2 open label extension study reveals a favorable safety profile and low ABR. An update on this full safety and efficacy data from the phase 2 open label extension study will be presented at the late breaker session on Friday. Bleed management guidance with detailed guidelines has been developed for proper management of breakthrough bleeds and surgeries. And so we look forward to seeing the safety and efficacy of fitusiran as it continues to be evaluated in the ongoing global phase 3 ATLAS program. And I wish to thank all the patients and their families, investigators, and the study site staff who've been contributing to all of this work. Thank you very much.